through 47, you're what we used to refer to as requiring split limits of liability. And we used to call it combined single limit. It's a lot of times these policies are either issued with one format or the other. Did you get anybody from the industry mention to you that might be a workflow issue for them?
No, sir. Did not come up. I mean, I mean, straight up answer is no, it didn't. That doesn't mean it won't come up as the bill travels.
It doesn't affect what you're trying to do at all, but it could be a systems issue for insurance companies or whomever's trying to track the compliance with the law. So I would suggest maybe we'll find out earlier rather than later. So.
Yes, sir. I will, and that's a great point, because with any big company, let alone insurance, it's not like flicking a switch to make something work. If there's a systems issue, it can shut everything down. So I will make that proactive. I'll make a proactive question on that just to make sure.
Great work on a great bill.
Thank you, sir.
Number 11.
Thank you, Mr. Chairman. Chairman Golick, thanks for bringing this bill. And as you know, some months ago, I was a Uber X driver for a little while. And one concern I have as we look at the insurance piece and other bills that we're considering is the uniqueness of what Uber X is. You're essentially creating part-time cab drivers. And, of course, the insurance piece is one important piece, and I appreciate you bringing the bill. My question kind of relates to the minimums, the coverages that you're having here. How do they compare with a typical commercial policy for maybe a cab or a limo driver? And my concern is that the cost of doing business becomes such that you kill off this unique feature that Uber offers of UberX.
I appreciate the question. Let me tell you, what we didn't want to do is put minimum limits in there for obvious reasons. I'm not an insurance agent, but we've got insurance agents on this panel, and they'll tell you don't get minimum limits. So I think that stands on its own. We wanted to, I really appreciate the question. I should have said this in my presentation. In the 100 to 350, what we attempted to do was to bring it in alignment with what the required coverages are for a limo that's under 12 passengers. Okay. So these limits mirror those. Okay. I don't want that to be taken as we need to think of that industry along with limos and taxis, because I know that's a very different subject with different legislation that's pending right now. We wanted some level of consistency. Right. So that's the straight answer in terms of how did you arrive at that. We arrived at that because that matches what the required coverages are for limos for 12 passengers or under. There's another higher limit for 12 or over. Of course, that wouldn't make sense. So we thought that was a good balanced approach on doing that.
Thank you.
Yes, sir.
Before we take a vote, 'cause I don't see any other questions, I want to commend Chairman Golick and also the insurance folks and the credit unions, banks, and the Uber and Lyft for working on this bill. This bill has been in process now since summertime sometime. Yeah. And we've had numerous meetings, large groups in that meeting. But they have done an outstanding job, and I want to commend Chairman Golick for the work he's done on this. I'm ready for a motion on this.
Thank you, Mr. Chairman.
I'm ready for a motion. All right, second. All in favor say aye. Aye. All opposed, like sign. Very good. Bethel, you gonna have 2 bills coming your way pretty soon. You've had an opportunity to hear the discussion. Okay. Next item on the agenda, and I know there's several on here. You have to go to appropriations. The next item on the agenda is a hearing on Senate Bill 1. So those of you who have to go to appropriations, I understand. But I'll ask Chairman Bethel to come up and make his presentation on Senate Bill 1.
Thank you, Mr. Chairman. First, I would like to appreciate the excuse you've given everyone. Most of the time when people walk out when I'm talking, they don't have a good excuse like an appropriations meeting. So I appreciate that. in all seriousness, I want to thank the chair and the members of the committee for giving me an opportunity to present Senate Bill 1 for your consideration today. I am extremely mindful and consider it a personal compliment that we're hearing a Senate bill in a House committee before crossover day. I recognize the rarity of that, and I do appreciate it. And I do look forward to working with a lot of members of this committee on your legislation as they come across the building to the Senate side. Mr. Chairman, a lot of times people talk about what their bill does, and I want to start by talking about what Senate Bill 1 does not do. First and foremost, it doesn't solve this problem. It is not the silver bullet. It's not the first step or the final step. I believe it is a right step, and I believe it is the next step in Georgia's fight against the public health crisis that is autism and autism spectrum disorder. For those of you who've been on this committee before, this bill will look very familiar. There's a couple of minor and pretty much administrative changes to what the Senate passed unanimously last year when Chairman Golden was carrying this legislation. Of course, we passed Senate Bill 1 unanimously earlier this year. You will recognize that we are requiring in this legislation private health insurance sold in Georgia to include coverage for autism treatment, most specifically the ABA treatment, applied behavioral analysis. Why is that important? Well, it's important because it's the most effective treatment. It is the treatment that gives us the greatest return on investment, and it is the treatment that has us give an answer to families in Georgia who go to their pediatrician and receive a diagnosis and are told there is a best practice available, but you can't have it. So what we try to do is strike a balance between, I think, a shared fiscal responsibility that we all have to our constituents, to our state, to the business community, and to the families we represent here in Georgia, and to the individuals who are going to be in our public school systems, who are going, if untreated and unrehabilitated, to be in our juvenile justice system, who are going to be in our adult criminal justice system, and are going to be lifelong consumers of our mental health services in the state of Georgia if we don't rehabilitate them. And I say rehabilitate because that's what ABA has the prospect of doing. We are talking about children who are able to restore or reach grade level. The word normal is frankly not fair because I have 3 children and I don't consider any of them normal. They're all extraordinary. They're all wonderful. But when we talk about normal function, meaning that they are able to be productive members of society, parents, family members in a way that we would all dream of. There's a lot of statistics that float around autism. You'll get packets. I'm sure you've gotten them already. Because we're not taking a vote today, Mr. Chairman, I've asked the advocacy folks to just simply provide data to you and the members of the committee after the meeting. There's no reason for you to carry a big old stack of papers out of here. That doesn't seem to me to be the most productive way to consider issues, and I hope you'll appreciate the indulgence of that from my standpoint. The bill addresses children 6 and under. From my standpoint, that's a critical position because that's before their school age. If you talk to your school districts that you represent in your homes, I assume you're going to hear numbers like I hear from the districts in from the school districts in my district, which is a student with an autism diagnosis that gets an IEP, which all of them do when they walk in the doors of our school systems, are going to cost that system between $10, $12, sometimes I hear $14,000 per student per year on average. Talk about what that looks like magnified out when you talk about all the other services that demands. Autism Speaks will tell you that nationwide individuals with untreated autism or unrehabilitated autism will cost on average $3.2 million additional taxpayer dollars over the course of their life, just by the services they require. So I say all that, and what I'd really like to do, Mr. Chair, is I will walk through the provisions of the bill so that the committee's familiar with it, and then I want to talk a little bit about some of the the things that I think are legitimate concerns that I have had and continue to have, and talk about them as by way of discussion. First, you'll see that the bill doesn't apply to insurance products, and I'm looking on the first page in Section 1, that are not general health insurance, so not dental plans, not vision plans. In other words, you're not requiring it to be delivered there. We define the applied behavioral analysis method. You'll see that starts on the bottom there in line 25. We define autism spectrum disorder on the top of page 2, paragraph 3 there on line 30. And then we talk about the treatment for the disorder, which sort of balances the rest of the first half of that page. What we require starts on line 53. This is what we would require of policies that are issued. You'll see the 6-year age limit is the same as it has been for the last at least several years. We require treatment for assessments and evaluations, which are of course the most critical component. And we talk about, flipping over onto the next page, we will not limit the number of visits. Our cap is on dollars and not visits and treatments. There is a $35,000 per year maximum that is in the requirement. Doesn't prohibit someone from going above that, but this would be what would be required. And if it's a policy that does not cover prescription drugs, obviously it wouldn't have to cover prescription drugs in this section. Looking down into line 77, you'll see that this is considered to be additive in nature. This is an added benefit. That is to say, an insurance company wouldn't be able to say you're drawing some other benefit and it would offset the availability of this benefit. And then in line 83, these are the exemptions that we would have from being covered by this requirement. And that is if your actuary can demonstrate that it's going to cost you more than 1% of premiums or claims, and that's what I sort of refer to as a circuit breaker. If costs are running away, then you would be exempt from this requirement. Similarly, if you are the smallest businesses, employers with 10 or fewer employees, then you would also be exempt. And then another new piece for the committee that heard this last year, the members that heard it last year, on line 132, we have included what appears to be, I think, a best practice of other states who have this requirement, and that is a report from the Department of Insurance. We're going to collect the data so that we can look back and determine where our experience is and has been in Georgia, and how it compares to other states, and certainly how it compares to what we are projecting now. Now, Mr. Chairman, as far as I think objections that I consider to be, frankly, good objections, and that is a philosophy of not adding insurance requirements. I think that's where I started in this discussion, in this debate, and so I think that's a legitimate philosophical viewpoint. I will say that for my part, I am persuaded that this is in the best interest of the citizens of the state of Georgia for several reasons, and I'm certainly willing to talk about them. I know we're somewhat time constrained this morning, so I'll try and hit the highlights and obviously make myself available for questions in that respect. And then also the cost control element. I'll talk about the cost control element first because I think it's the shortest. Nationwide, in states with an autism requirement. Now, understand that from a cap standpoint, some of them have no caps, and there's a broad spectrum. You'll hear 33 cents per member, as opposed to per covered life for those of us that track those sorts of things, per member per month. The states with caps that sort of most similarly mirror Georgia are seeing numbers closer to 26 cents per member per month. Because when we sat down and worked on this bill, and when Chairman Golden actually sort of got the operative provision, I hear from the industry a lot of we're worried about the cost. These are my friends. I respect them. Their worry has never translated into actual math, and they are the experts in math. I believe if their worry was supported by real math, they would be giving us real numbers. They are the ones doing this, and we're collecting data secondhand and able to come up with reasonable projections. So I appreciate their concerns, and that's their job. Their job is to protect their customers and certainly their plan participants. Back to the issue of a requirement and why this is something we should require. Mr. Chairman and members of the committee, this is not an opportunity for us to ignore. This is a situation where when you look at the statistics and you look at the diagnosis trends, if you walk through an elementary school in Georgia in 5 years, statistically, every other classroom is going to have a child diagnosed in the autism spectrum disorder. That exceeds the rate of childhood HIV/AIDS, childhood diabetes, childhood cancer combined. It exceeds that. And families with these children have access in theory, but not in practice, because the market doesn't allow them to access ABA treatment. There is no rider. There is no real meaningful way to go access this benefit as an individual citizen. It has been I think, valid criticism of what we're doing, that it doesn't reach everyone and doesn't rope everyone in, and that is absolutely true. I didn't run for Congress, and I'm sure glad. I can't regulate an ERISA plan, and neither can any of us. And so that's just reality. But we regulate health insurance every day, and none of that touches ERISA plans. So we don't use that excuse in other areas. I don't think we should use it here. The other part of that is, when I was driving down, Mr. Chairman, this morning from Dalton, people were already working, not just in the carpet mills and in the productive capacity, but people were out there brining the streets and working to provide us access. But they didn't get every street, and they won't, and they never will. They provide main corridors, main access channels, trouble spots and pinch points, so that we can get where we need to go, and then there's some roads that are not treated. That's the reality of limited resources in government. I believe that by touching this segment of the market, we will improve flow for the balance of the market. What do I mean by that? I've been a plan sponsor, plan administrator for a self-funded insurance plan. And yes, I have checked before I became sponsor of this, just before you asked, we provide this benefit. Sort of important to know that, I guess, before I signed on. But as a practical matter, that's a difficult thing for a self-funded plan to do in a state where there's not an infrastructure already built out. Because as a general rule, what we do is buy network access, and then we match our plan onto an existing plan that's offered within the state. That's generally how it does. And so then when you ask for a deviation, they're going to charge you extra, because that's not baked in. That's not part of what they already offer. And so when you deviate, you're going to pay an administrative fee and a per member per month, or a per covered life per month, depending on the structure of what you're asking for, addition. So anecdotally, and I don't have hard data, and I don't think anybody does because I've asked for it and looked, we see that in states where there is a requirement, there's a higher participation rate of ERISA plans in adding it. It's because it's available, and because the cost of accessing it is probably significantly lower when they're not adding it to an existing baked-in plan. So with that, Mr. Chairman, I would certainly yield for the questions of the committee. I know everybody has places to go this morning, and I don't know what the future of this bill stands in this committee. I know we're not going to take a vote today, so I want to make sure I'm responsive to your committee.
Okay. You and I have talked, and I've talked with practically, well, almost everyone in the audience about this particular issue. A couple of concerns that I have, and it's a question that I haven't received an answer for yet. First off, I understand, according to the CDC, that 1 out of every 68 babies that's born will have some degree of autism. And that is a real national concern. So the two questions I have is related to that. why didn't the federal government include it in the Affordable Care Act exchanges? And the second question, and I think more important, is of the people in Georgia who have insurance, 75% plus are in insurance plans that are federally regulated, or ERISA plans. You know, and I may be wrong, but I've got the feeling that all it would take would be the stroke of a pen, and autism coverage could be put in the exchanges and the ERISA plans. Now, you're talking about 75% plus of the people in Georgia who have insurance fall in that category. So my question is, and you know, like I said, I haven't got an answer for this, why didn't the federal government do it? Because I've made the statement ever since day one on this, if we could get the ERISA plans to cover it, so you got such a large group, 75% plus in it, this issue would have been solved a long time ago. Because this would have just sailed right through, because you would have such a broad group covering.
Mr. Chairman, I share your questions, quite candidly. First of all, my list of why doesn't the federal government is very long. So there's a lot. I've got a lot of questions on that list. Why doesn't the federal government list? And you are right. There are plans, and as I indicated, there's parts we can't touch and we can't regulate. That being said, I do think that our constituents expect us to solve the problems we can solve. And so the part that we can touch is what this bill touches. And that's there. And we can lead by example. I do think that I can speculate as to why Congress or why the President didn't, and that has a pretty long list. Certainly when you have a large majority of states now that have some form of a requirement, they may have simply said that's not the juice is not worth the squeeze, so to speak, because most of the country has some sort of a requirement and a benefit, so that when they're sitting there at the table, and I can only imagine the god-awful deals that were made when they decided what was in and what passed in the ACA, they might have simply said, this is not worth the fight because there's already so many places where treatment is required by state law, and that we're going to just simply allow the market to continue and work in that direction. They may have been uncomfortable breaching the subject of habilitative services, and that's certainly a possibility. But I wasn't there, thank goodness. I got no interest in being there, and so I don't really know why they wouldn't or did not. And you're right, they could change that, and I think there's good cause to argue that they should. But none of us sit in those chairs. This is what we can reach, and this is, I think, also a way. You indicated those 75 folks. A significant number of those folks are on the state health benefit plan. And of course, we now have the benefit, actually up to age 10, a broader benefit than what we would propose in this law. Also, nationwide numbers that I've seen indicate that around 40% of ERISA plans, I don't know if that's covered lives or number of plans, and how big they are. There's a pretty impressive list, and I know the advocates will make sure that those are in your offices for you to look at. So it's General Motors to General Electric, it's Newell Rubbermaid to Boeing. There are a lot of large and small ERISA plans out there that have the benefit for their plan participants. So it's not as though there's 75% that are naked. It's just some subset of them are receiving it and some aren't. And like I say, we can't, from a procedural standpoint and a legal standpoint, we can't compel ERISA plans. So it's like I indicated, it is a legitimate criticism of what we're doing. But most bills we pass, I think, have legitimate criticisms. We make choices about where our values are and where our priorities are every day. And I think that the opportunity to capture somewhere around 15-20%, well, not 20, probably 15 to 17% of the lives of Georgians, and what we can touch, is worth leading and creating that infrastructure that then makes it easier and more appealing to ERISA plans in our state to participate.
In regard to, and I'm glad you've referenced that this does not apply to ERISA plans. And in reality, the only thing it does apply to is small business and individual plans.
Yes, sir.
The perception is out there that, we got to pass this bill because everybody in Georgia would have access to it. I had a call yesterday. The guy, very nice. We talked probably 15 minutes on the phone. And I finally asked him who he worked for. And he worked for the post office. Can't help him.
That's right.
And what we're looking at, and here I'm talking to you I'm not a small businessman, but I'm talking to you if I were, because this is what these small business people have been telling me. We cannot afford an increase in premium, regardless of the reason. We had a guy testify last year that he's from over at Conyers. He had 50 employees. Just came up and said, regardless of what you do with this, we've made the decision we're going to drop insurance for our employees because premiums have increased so much. These are the ones that is impacting small business who are the least likely to be able to afford an increase in premium regardless. So my question then is, how do I go back home and say, oh, by the way, we just voted to raise your insurance premium, and now, what are you going to do?
Yep. It's a great question, Mr. Chairman, and I now work for what's no longer a small business but once was, and it's a family business, and so the process of building and growing a small business is near and dear to my heart. I hope it really should be to all Americans, because that's why we're here, in terms of the economic powerhouse that we are. And I've got a little soldier from our friends at NFIB that sits in my office in a place of a distinction, because I'm proud of that. I think that there's a balance that we always strike in all that we do and all that we require. When you look at the investment that's here, I think that we've taken the steps to make it fiscally responsible and in tune to those concerns. Certainly that doesn't mean that there won't be somebody who says this is the straw that broke the camel's back. If that business is in that precarious of a financial position, I kind of wonder whether they're going to be able to pay their property taxes when all these children show up in elementary school and cost the district an extra $10,000, $12,000, $14,000 per year, each district, and we have to pay for that. When the county commissioners have to raise their millage rate because their juvenile justice demands have gone up because these children are hitting that system. When the state has to impact their business, because that's the reality of it. People pay taxes, and the services that are provided require funding. And here's a mechanism to take an investment that I think, relatively speaking, is substantially small. Just take, for example, if we have a $35,000 benefit for a child for a year versus $90,000 per year if they're housed in our juvenile justice system. Just for that one child, that's a clear trade-off. If we derive the benefit, right? The professionals tell us that this is a worthwhile treatment and it works, and we certainly see the evidence of that in the children that are rehabilitated. And let's be clear, as I said in the beginning, it's not a silver bullet because it misses part of the population. It's not a silver bullet for every child and every family. There will be children who receive ABA therapy who are not restored or not finish in productive capacity. That's the reality of the disorder. But to that small business owner, like I say, if you're in that precarious of a financial position, are you going to stay in business? And I don't want to be in the business of watching anybody go out of business. But if you're really that close, that $3 per member.
No, they're not talking about going out of business. They're just talking about dropping insurance.
Well, if $3 per member per year is a cost that can't be borne by that business, I think candidly, probably for more discussion after the cost, I think we have options to relieve some of that burden on small business, and I'm for that. I mean, I think we can do more than, frankly, trade off the cost that we're asking them to bear here. Those are bills that have to start in the House, but that's for you guys to work on. I think we can do that. But having said that, I think that the alternative of doing nothing leaves our communities that include all those small businesses in a situation that they can't withstand either. So I mean, it's one of those catch-22s. I don't want to see people lose coverage. Certainly don't want to see people driven to the exchange-only world of coverage, because that's in my mind, that's substandard. We talk about substandard plans. That's a substandard offering to our citizens. But I also believe that when you look at the alternative, the opportunity cost, as it were, and we talk about in economics, the opportunity cost of not treating, I think exceeds the requirement to treat.
I got two more comments, and we got two more questions I want to ask. One of the biggest concerns, and you've alluded to it, is you're picking winners and losers, because you're talking about 15 to 17%. Because if you got two moms at a soccer match and one says mine's getting ABA treatment, and the other one says mine's not. One's working for a hardware company that's got 15 employees, and the other one's working for a large self-insured that doesn't get the coverage. And then also, it's kind of codifying ABA treatment, but there are other treatments out there that may be more applicable to a particular child and to a particular situation, such as floor time and these kind of things. And sometimes ABA and floor time are used together and this kind of stuff. So there's all kind of options out there. But I'm really concerned about this winners and losers. And I know we create winners and losers every day, sometimes on the House floor and on the Senate floor. I want to talk to you at some point, and I know we're in a hearing today, so I can say this. I got with OPB the other day, and a couple of things. I know on your thing you said if somebody does an actuarial study on an annual basis, then if it raises their premiums over 1%, then they can opt out. Okay, they got me the figures of what an actuarial study would be through the American Actuarial Academy or whatever. So it's going to cost somewhere between $10,000 and $20,000, because it has to be approved by a certain group. This kind of stuff. That presents an issue. Another $10,000 to $20,000 annually. But my personal feelings, I had rather see the state of Georgia implement a statewide sales tax of a quarter of a penny or 20% of a penny to cover everybody versus covering 15 to 17%. And here again, I asked OPB to get some information, and I'll provide this to you. And if you don't, they did They did it three ways where they had it based on poverty levels. 400% of federal poverty level, 238, which is what Peach Care qualifies for, and then with no poverty levels in there at all, just open to everybody. And the cost would be if you did it based on a 30% utilization rate, because that's what because they checked other states, and not everybody uses the high end around. They said it cost $208 million if they did the 36,000 per year. But to me, that's fairer than 15 to 17% getting treatment. And I'd support a sales tax for statewide. Everybody's covered autism. I'd vote for it today.
Well, thank you, Mr. Chairman. I appreciate the support. I know you guys have a big tax reform bill that's out there. Maybe that's something that the House will look at.
We got that. We got that big transportation bill that costs mega bucks, and $1.5 billion or whatever per year just for maintenance and all. And I know there's a lot of issues with that. And there'd be a lot of issues with this, because you'd have other advocacy groups want to to attach to it and all, and then you'd have to be sure that it's properly worded so that, you know, it'd be only available for those people who lived here, say, 2 or 3 years.
Yeah.
Otherwise, you'd have people moving in all the state. You know, because if I had an autistic child and Georgia was offering it, I'd move to Georgia. So you know, we have to do those things. But I'm really I want the most people covered as we possibly can.
Yes, sir.
And I just have an issue with 15 to 17% when you got another 85 to 83%. That's not.
If I could, Mr. Chairman, and I think you raise a great point. I mean, I think it's a valid criticism, but I think it's a valid criticism every time we regulate anything in the health insurance market, because that's the same argument. It's the same issue every time. We can't touch that part of the plan.
But
and
we could with a sales tax because it's not insurance.
It's true. I would say that from my perspective, but I certainly, the chair, it's fine to pursue the plan. I think from my perspective, creating what I would see as somehow you'd have to have a bureaucracy to administer that. I'm not entirely sold on the fact that government is the best deliverer of health care services. We have already an existing efficient model within the insurance structure and private insurance structure that's out there that can deliver these services. And again, take that next step. I don't know that, like I said, this is not the final step. There'll continue to be that discussion. In regards to the question of the cost of an actuarial study, the bill doesn't require an annual actuarial evaluation. It makes that available. I think that when we take the data that we're going to recover and require the insurance commissioner to collect and report, that we will be able to determine if and when there's a need to actually request a study. Hopefully, you'll see what you see in every other part of the insurance market, which is insurers are going to offer the same plan to multiple employers, so that running the actuarial data won't necessarily be about $20,000 for one employer. It will be for a plan. Mm-hmm. And so that's where they would be looking. And to maybe address the issue, 1% sounds small to some people. To me, it sounds really big. Mm-hmm. But I think it's a way of having that guaranteed stopgap. In a state like, for example, Virginia, who now has 2 years worth of data with a $35,000 cap. They have a little bit more expansive benefits in other parts of the plan, but their cap is 35, which I really think is probably the most important piece in terms of driving cost. Their first 2 years of data in their statewide report show that it's 0.04% and 0.06% of claims paid, not anywhere obviously close to 1%. But that data would then be available. And if you saw that number moving, or if you saw any irregularities in that data, that would probably be a good reason for an employer to go to their insurer, their provider, and say, we would like to talk to you about doing an actuarial study because we may be close to that number. We're seeing a lot of experience, and they could have that conversation. I would not imagine that being something that most folks would do on an annual basis, in part because reason and experience tells us that we're not going to be close to that 1% based on other folks' experience, unless Georgia just has some explosion of autism diagnosis.
Okay. Mr. Tarver.
I'll be very, very brief, but I didn't, if it's possible for me, I didn't come here with any questions. These questions are just questions I've had here now, and as you know, I've probably got more calls about this and emails than anything we have going, including the transportation. Things you said that, as I talked to Ava's mom that day in my office, I didn't know who she was until I got through, and then I told her what I thought, and then I found out it was Ava's mom, and I've been very clear. I'm pretty neutral on this bill, but you said $338 if you're running a small business, and as you got to understand, this is not about money versus your child's health. It's about what's best for everybody in Georgia. $338, you got 100 people. I mean, $338?
No, sir. $3 per member per year.
Okay, you got 100 people. Is what I based.
If you got, that's right.
100 people, $338.
Well, we think it would be closer to 300, but
okay, say it's 300 then. I'm not trying to argue. You got $300. Well, you got this business has got 100 people wanting $300. And all of a sudden they got 1,000 people wanting, not just for insurance. So that's 100 people is $33,000, and 1,000 people is $300. $338,000. My point is, it's not about just a company going out of business because they got to supply 30. Now, back to the subject at hand. $35,000. At what age can these children be entered into this therapy? Is it 2, 3,
Well,
1?
according to the Act, it would be birth through 6. As a practical matter, it's going to be beyond birth because getting a confirmed diagnosis of autism is going to be later.
Now,
It doesn't. Can I jump in just a second? I think most of the diagnosis, and y'all can correct me by shaking it, about 2 to 3 years of age before they actually diagnose.
Our average diagnosis age in Georgia is unfortunately around 4.5, I think.
Yeah, but you could get it at 2.
Well, you can get even younger than that. At the Marcus Center, they're doing with infants.
Yeah.
the point being, does this take 4 years to see the effect that we're looking for, or 2 years, or?
It depends on the patient,
Okay.
Representative. It's some of them may not even have a full year's worth of treatment and be done, functionally done with that.
Okay, but it may take
All 6
less
years.
than 1 or 6 years.
Yeah.
Okay, if there's say there's 6% of our population's under 6, 300 to 21 million, and we got that. It's 1 out of 6. 1 out of 68 would be 300,000 kids with autism. $35,000 at $1 billion. I mean, that's what it would raise at that 28 cents in America. $1 billion would treat 2,800 kids, or 28 within that year. My point is being on the paying end of insurance. If you've got 11 employees at $18,000 a year, that's $198,000. If you put $35,000 exposure in there, your premium has to go up more than 1%, and that's why I can't figure where the model is. If you have another $35,000 exposure on 100 people, I mean, you're not going to have but 30. But if you had another,
I'm not an actuary either.
I don't want to be negative, but my point is, I don't see how the bill's not designed to fail. And I know you say there's models in other states, but if you've got 11 employees at $18,000 a year, that's $198,000. And if you have a $35,000 claim in there, your premium has to go up over 1% because these things are down to a science on what the exposure is going to be.
Thank you, Representative. If you have 11 employees, given the birth rate, I mean, statistically, 6 of them are going to be female.
Yeah.
Depending on what business you're in, but just population, just barely over half of our population are women. So 6 of them are going to be female. The chances that each of them are going to have a child in that year or in that 0 to 6 age range. I mean, when you get down to actuarial science, I mean, it's not guessing. I mean, they're basing it on real claims experience in other states when they get to those numbers. And I, like I said earlier, I feel entirely confident that if there was actual math that supported the runaway cost claims, we would see it. Okay. We've been doing this for years. I would like to respond to the question about the demand for small business, in part without taking advantage of your heart, because I know how you ran your small business when you had one. The other side of that is when you have an employee that has a child with autism, you're going to come out of your own pocket if you don't have coverage.
Our insurance covers them.
Well, I understand, but if you don't have the coverage, then there's going to be a lot of small businesses that come out of their own pocket because they've got a child with an employee who the pediatrician is saying there is a service available that is highly effective, but it's not on our insurance plan.
Okay. This is my last statement, and I'm not negative. The statistics show that 1 out of 68, there'd be 28. You could treat 28,000 kids at 28 cents per capita in the United States at $35,000. It's $1 billion. You could treat. You divide that by 35,000. It's 28,571 kids, and there's 300. There's some 300,000 that will have autism, and I don't see how it works out. I don't.
Well.
And it goes back to what Chairman Smith said. We're going to give it to these people, and these people aren't going to have it. And I appreciate.
You're assuming that in your math, you're assuming that everybody reaches the cap which is not actually the case.
Mm-hmm.
And you're assuming that everybody requires the ABA therapy, which is not actually the case. I mean, I hate to stress it this way, but there are people for whom this is their job.
I understand.
And it's not you or me.
I understand.
And their data, it doesn't match your math. And I'm not in a situation, because first of all, I don't know actuarial science that well, but I can make sure we get somebody who can come see you in your office and walk you through the general mathematics of it. But it's not, if it was as you presented, there wouldn't be 30 states with requirement coverage, and those 30 states would be shutting them down because of, if that was the real math, it would run away with all the costs.
Okay, Chairman Golick.
Thank you, Mr. Chairman. Chairman Bethel, thanks for bringing the bill. I'll go ahead and demonstrate my part of just the beginning of my ignorance. It's a multi-stage process. And I'm going to ask you a question. I'm going to also glance over to Mr. Thompson as well. Under the affordable, we have dozens of mandates, right, that are required in the state of Georgia, just off the top. I mean, dozens, plural. Do you happen to know the exact number? There are a lot of them. It's like 40?
35 or 40.
Okay. I just don't recall this, under the Affordable Care Act, is there a prohibition because of the Affordable Care Act for us to go ahead and reduce that number of mandates? In other words, my feeling is not all mandates are created equal, as much as some folks would like to think that they are, but they're not. I mean, we just have mandates in there. You look at them, you just, first of all, you don't know what it is. And then to wrap your head around it and figure out, well, why do we pass that at some point, and what's that really doing in terms of a cost driver? Some of them are larger cost drivers than others. Oral contraceptives is a huge cost driver. We understand that. There's a societal demand, and we get that, right? Just as one example. There are others that are not as much. Of course, they're not as great a cost drivers. Yeah. My question is, do we know, is there a prohibition under the Affordable Care Act? Are we able to go ahead and eliminate existing mandates today and put in others in their place if we wanted to? Is there a prohibition under Affordable Care Act?
I'm not aware of a prohibition. I mean, if we removed a mandate that was something that was included in the Affordable Care Act, it would sort of be a nullity.
No, right. I'm just something that was pre-existing to the Affordable Care Act that we've had. I'm not picking on them. We have a mandate, athletic trainers. I don't exactly know the substance of that. That's one that just sort of jumps out at me. There are others of that ilk, but the question is, are we able to go ahead right now if we wanted to and eliminate that mandate or others?
I think we can eliminate mandates, but the Affordable Care Act was based on the mandates that we had in place December 31st, 2011, I think. Part of the problem with mandates, if we, and I think this bill said that it excluded the exchanges. If we do a mandate and add it to the exchanges, then the taxpayer has to either subsidize the insured or the Affordable Care Act or something.
Because it becomes an essential health benefit if we apply it to exchange product, which if you'll look on page 4 on line 120, it's why it's out. Because if we deemed it for Affordable Care Act purposes an essential health benefit, then we would have to subsidize it. The state would have to essentially make sure it's available.
If we deemed it for exchange purposes, but of course we didn't set up our own exchange. Is that relevant?
Not to that analysis, I don't believe. But I think the answer to your question is we can remove in state law mandates. I think the chair is correct that the structure of our exchanges was based on the exchanges that were created for us were based on what was required at a certain point in time.
So that would really preclude removal then, correct? I'm getting a head nod from the Department of Insurance, so I'd take that pretty seriously. Yeah. So that would preclude removal then. Okay. Because the motivation, obviously, and if there may be a nuance in there that we could possibly explore, and this is, I'm just for purposes of discussion, if there's, there are some mandates on that list that are antiquated, probably is a good word, and there are other potential mandates such as this one that are not antiquated. Just to preface that, there's an Autism Speaks little award that I was for some reason given many years ago, and it was so long ago I don't recall what for, but it was, and I appreciated it then, and that was before, we always talk about, well, this was, this was that before it was cool. This was way before the issue got as big as it did, and why? Because it's a burgeoning issue with regard to just the sheer number, the volume of diagnoses that have occurred across the spectrum from mild to the strongest. So what I'm trying to do from a practical standpoint is to find a way, if there is a way, to see, well, if we have some mandates that are not as warranted as they may have been way back when the General Assembly in its infinite wisdom went ahead and put that into the code, maybe that's, number one, a path if we can legally do it. Then the question is, well, if on its face it cannot be, maybe is there another way that we haven't explored from a legal standpoint, from a strategic standpoint, frankly? So that's one part of the, let's think about that analysis. The other is, and I just wanted to, my sense of it is, I think a lot of the rank and file members are under the impression that we want the governor, to his credit, included it in the state health benefit plan, and my assumption is, but I don't know this for a fact, my assumption is that part of the motivation there was to get some sort of number feedback, I'll call it, in terms of what the results would be, so the General Assembly, at some, a year later or whenever the proper amount of time is, you and I both know a loss cost trend is really what, 3 to 5 years? Well, we may not have that, really, but if it can at least take a year or two, maybe even just a year, and take some numbers and then be able to extrapolate those with a straight face and say, this is what we can reasonably expect because this is what occurred during this particular, time frame. My heart wants me to say, yeah, let's just go ahead and do it. My head tells me we probably might want to, I assume the governor's lead was to put this in the state health benefit plan, see what the results were going to be, and then to reasonably extrapolate from there, and then to make a cogent decision based on what numbers we could get. Is that a fair thing to say, or am I just making that up?
Well, thank you, Chairman Golick. First, I just want to tell you we're excited about giving you another opportunity to get an Autism Speaks Award that you know what
Thank
it's
you.
about, and you'll remember. And I do want to say this about the idea of and I'm using my words, not yours, but,
Sure.
but sort of trading mandates. One of the unfortunate aspects of the political process, and I think we're all too aware of it, is that too often as has happened with this particular bill or previous iteration of this bill, is that one interest group gets pitted against another, and we start. So anytime we have a discussion, we say, well, we're gonna take this and take that. Then somebody else is going to be here, and I think that discussion should be done on its own, personally. I think that we ought to. I think our Mandate Review Commission might actually ought to consider a review of existing mandates and see if there's a way to clean that up, independent of saying we're gonna trade and swap, because I think that means that what we then are saying is which do we value more.
That's exactly right,
and that's happened here.
I have no problem with that.
Well,
I mean, I have zero problem with looking at somebody and say, look, this is a more pressing public priority than that. And defending it.
Yeah, and I think we can do that here. I think we can say this is
because that creates a soft landing for the gentleman's I think it's a collective priority.
I think there are other options, and
Okay.
we'll have conversations, I'm sure, as we continue discussion that I think are, from my perspective, more accessible and don't get us in the business of saying it's you versus them. In that sort of model.
And that's not where I'm trying to go. I know that's where things inevitably devolve into, like tax reform somebody brought up earlier. That just, unless it's a full-scale, broad reform, we end up, you end up in some aspect of winners and losers. But on this particular thing, I think if we all stood up at a town hall meeting and said, look, this particular mandate, I mean, we have mandates right now that clearly are more of a priority to the citizenry than others are. And if it makes some people angry, well, I mean, that's why we get paid the huge money that we do, right? Because to make those decisions. And I have no problem with that. I would bet you $1 that the vast majority of the membership doesn't have a problem with that, as long as the credibility of the choices, stands on its own. So I want to just put that out there as a strategic possibility as the debate goes forward.
The other part of your question, as I understood it, first let me say that I no longer have the distinct luxury and privilege of speaking as to the governor's motives on particular bills.
I spent 5 years in that capacity,
but
and then I was paroled back into society.
I guess I got credit for time served. I wasn't quite there that long. I do think that it is relevant data points and that we'll track. And I don't know whether that was, I've never read anywhere where that was the governor's intent.
I haven't either, but it just seemed to make reasonable common sense.
Having said that, and I'll say this, and y'all can all poke me later if it turns out to be that the data is the opposite, and I'm touting it, which certainly if it favors my argument, I will. But sight unseen, I would say that my experience with the state health benefit plan, if the numbers benefit me, then that's a really good sign, because the state health benefit plan has extremely high utilization rates relative to any other plan I've ever looked at. I don't know what that says about our employee pool or if it says anything, but it has pretty high utilization. And when you go and look at where how often they visit, how often they use in our employee base, it's pretty high. So I think that to the extent we use that data, that should be the high-end data when we look against Georgia, because, like I say, everything I've ever looked at there, and we can look at our experience in the state health benefit plan, and it consistently paces or exceeds the market. So in terms of our costs.
So is it reasonable for us to have some chunk of time to look at what we have intra-state, when that would be state health benefit? And I'm not talking about a 3 to 5 year look. Don't misunderstand, but just something.
236 of us, all came down and were elected to make those decisions. I am satisfied looking at the national data, the national trends, the 30 states that already have this data, and saying, I cannot imagine that Georgia is going to be mathematically so different from the rest of the union. I know we're excellent and superior and the best, but I can't think from a health standpoint that our experience is going to be so dramatically different that one plan's data that we're waiting on 1 year's worth of data
will provide some sort of statistical aberration.
Something that would
right.
would make me think that the vast decades of data is not more valuable.
I don't dismiss that. That's a point well taken.
Mr. Williamson.
Just a couple of quick questions. You mentioned you're affiliated with an ERISA-based plan. Is your cap $35,000 a year as well?
It's not, and I don't know the specifics of it right now. I'd have to get my benefits administrator to give me the number.
And we've talked a lot about the state health benefit plan having similar coverage. Is that capped at $35,000?
Somebody remind me. I think it is. I think it's 35. I think that's the number they used. Yeah.
And because I didn't find, if it's in here, it seems there's a lot of vagueness about like copays, percentage pay. Is it a straight indemnity that is paying 100% of each visit until 35,000's hit? How would it be implemented?
It's subject to copay. It would operate under the rest of your
as any
plan.
other covered
yes, sir.
condition.
Yeah.
Okay. Thank you.
I'm sorry. Okay, that looks like the last question. Anybody else have another question? We've got some people who wanted to speak. The time is out. We've got to go to rules. We will have another hearing. It's like the senator said, we don't normally listen to Senate bills until after day 30. Today's day 22.
I appreciate it.
But we will have another hearing on this, and it'll give everybody a chance, and plus give us a chance to kind of talk a little bit more about the Mandate Study Commission and all. And I will tell you this, the Mandate Study Commission, I'm chairman of it, will probably meet, I'm almost sure, I can almost guarantee that we're going to meet this summer, and we're going to take a look at all these other mandates that's in there. And I don't mind telling somebody, this doesn't deserve to be a mandate. And so we'll go ahead and adjourn now, and because several of us have to go to rules. And we will adjourn and see y'all next time. Thank you.
Thank you, Mr. Chairman, members of the committee.